Welcome back, future nurses. Today's focus, nursing care of clients with seizure disorders, is all about calm, safe action. Turn the client to the side for airway protection, clear hazards, time the event. Avoid placing anything in the mouth or restraining movements, provide oxygen and suction as prescribed, and document features and triggers. We will also cover status epilepticus, seizure lasting 5 minutes or more, or repeated without recovery. When to activate the rapid response and prepare benzodiazepines by the intravenous route, plus medication teaching and post-ictal care. Stand coast, Pearl, safety, airway, timing, triggers, education. Before we jump into the next NCLEX topic, I want to give you something that could completely change your preparation. If you're aiming to pass on your very next attempt, the ultimate NCLEX crash course is your shortcut. Already trusted by more than 100,000 nursing students who cleared their exams successfully. What makes it different? It's an all-in-one package designed to cover every part of your NCLEX prep. Interactive live classes and easy-to-watch recorded lectures. 5,000 exam-style practice questions. 30 complete practice tests. Ebooks and PDF notes for revision. A ready-to-use student planner. Nigerian neuro questions broken down in detail during comprehensive lectures. This isn't just another review. It's everything you need in one place. Scan the QR code right now or use the link in the description to enroll instantly and grab free content, including PDF notes, practice tests, and NCLEX quizzes. You'll also get access to our Telegram and WhatsApp channels for even more free resources too. Keep you ahead. Let us now move forward into another high-yield NCLEX scenario to sharpen your clinical reasoning. A 23-year-old client who experienced a generalized seizure while at work is admitted to the hospital and is undergoing diagnostic tests. During the postictal nursing assessment, the nurse evaluates for different neurologic manifestations. The question is, which of the following findings is most consistent with an autonomic nervous system manifestation of a seizure? Here are the options to consider. Option 1 suggests numbness and tingling of the hands. Option 2 highlights changes in taste and speech. Option 3 identifies flushing and increased sweating. Option 4 mentions a subjective aura or sensation. The correct answer is option 3, flushing and increased sweating. To understand why, let us explore the clinical reasoning. Seizures can produce a wide range of clinical manifestations that are classified into 4 categories: motor, sensory, autonomic, and psychic. The autonomic nervous system is regulated by deep brain structures, such as the hypothalamus and brainstem. When these areas are activated during seizure activity, physiologic changes resembling sympathetic or parasympathetic stimulation occur. Recognizing these autonomic signs is important for accurate diagnosis and for anticipating potential complications. Flushing and sweating represent classic autonomic features, along with other signs such as pallor, tachycardia, pupillary dilation, piloerection, and epigastric sensations. These indicate that seizure discharges have reached autonomic centers, resulting in dysregulated sympathetic outflow. Now, let us analyze why the other options are incorrect. Looking first at option 1, numbness and tingling of the hands represent somatosensory manifestations of seizures rather than autonomic ones. These occur due to cortical involvement of the parietal lobe, especially the postcentral gyrus, which processes sensory input. Although important diagnostically, they do not reflect autonomic activity. Turning to option 2, changes in taste and speech are sensory and cortical disturbances. Gustatory changes usually originate from temporal lobe involvement, while expressive speech disturbances link to the dominant frontal lobe. Both are cortical features, not autonomic responses. Considering option 4, a subjective aura or sensation represents a psychic or experiential manifestation, often serving as an early warning of seizure onset. Auras can appear as unusual smells, sounds, or a sense of déjà vu. Although valuable diagnostically, these arise from focal cortical activity rather than autonomic dysfunction. Here is a quick memory tool to make this simple. Stand coast. Pearl, remember the acronym FAST pupils for autonomic seizure manifestations. F stands for flushing, A for autonomic sweat, increased sweating, S for secretions such as salivary or epigastric, T for tachycardia, and pupils for dilation. Keep in mind that sensory features like numbness or altered taste belong to cortical sensory pathways. Psychic features such as aura stem from cortical experiential centers, while autonomic features are marked by physiologic changes like flushing and sweating. All right, let us smoothly move into this next NCLEX-style scenario where seizure precautions are the focus of nursing care. The question asks, a nurse is developing a seizure precaution care plan for a client recently admitted with a history of epilepsy. Which environmental modifications should the nurse implement to promote safety and reduce the risk of complications if a seizure occurs? This is a select all that apply format, so think carefully through each option. The available options are keep the room dark and quiet, lower the bed to the lowest position, keep the side rails up and padded, provide soft, soothing music, ensure a warm, well-lit room, and make sure suction equipment is available at the bedside. Now, the correct answers here are options 1, 2, 3, and 6, which are keeping the room dark and quiet, lowering the bed to the lowest position, keeping the side rails up and padded, and ensuring suction equipment is available. To expand on the rationale, let us begin with the clinical context. Clients who live with seizure disorders face a heightened risk for injury during ictal events due to uncontrolled motor movements, impaired protective reflexes, and altered consciousness. Seizure precautions are therefore aimed at creating a safe environment that protects the client from trauma, maintains airway patency, and provides immediate access to emergency tools. This approach follows the NCLEX priority frameworks of safety, airway, and circulation. Looking at the correct options in detail, keeping the room dark and quiet is essential because flashing lights, noise, or other stimulation can precipitate seizures, particularly in photosensitive clients, and also help with recovery in the postictal state. Lowering the bed to the lowest position is another critical step since seizure activity can cause sudden movements or falls, and a low bed height minimizes the severity of injury. Keeping side rails up and padded prevents the client from striking hard metal during seizure activity, protecting them from bruises or fractures, and is considered standard hospital practice. Lastly, having suction equipment at the bedside is life-saving, as seizures increase salivation and reduce swallowing ability, creating a risk for aspiration. Suction allows the nurse to clear secretions quickly and prevent hypoxia or pneumonia. Next, let us address the incorrect options. Providing soft, soothing music may appear comforting, but it is not an evidence-based seizure precaution, and certain auditory stimuli could even trigger seizures. Ensuring a warm, well-lit room is also not appropriate because heat can increase neuronal excitability, and bright lights may worsen photic sensitivity, both of which may contribute to seizure provocation rather than prevention. To lock this into memory, here is a high-yield clinical pearl. Remember the acronym SAFEBED. This stands for Suction and Oxygen Equipment. Ready, airway maintained, flat bed in lowest position, environment quiet and dim, bed rails padded, emergency call light in reach, and do not restrain movements. This concise framework helps you recall the core seizure precautions you will be tested on in the NCLEX and ensures you prioritize client safety during care. Let us smoothly transition into the safety-focused NCLEX-style question. The scenario asks, a nurse is developing a seizure precaution plan of care for a client admitted with a known seizure disorder. Which nursing intervention is most essential to reduce the client's risk of injury during an unexpected seizure episode? The options provided are move the client to a room closer to the nurse's station, serve the client's meals using paper and plastic containers, maintain the client's bed in the lowest position, or apply soft limb restraints to the client's upper extremities. The correct answer here is option 3, maintain the client's bed in the lowest position. Now, let us carefully unpack the rationale to strengthen your clinical judgment. Seizures place clients at risk for multiple complications, including falls, trauma, aspiration, and hypoxia. Nursing seizure precautions are always guided by principles of safety, airway maintenance, and injury prevention. According to NCLEX frameworks such as Maslow's hierarchy, where physiologic safety is prioritized before psychosocial comfort, and the ABCS, airway, breathing, and circulation, our interventions must first eliminate hazards and create conditions for rapid airway access. Lowering the bed directly reduces the chance of severe injury by minimizing the height of a potential fall and provides a safer environment both during seizure activity and afterward when the client may be confused or weak. Turning to option 1, moving the client closer to the nurse's station might seem helpful for observation, but this does not directly prevent injury when a seizure occurs. Observation without environmental safety measures is not sufficient, So this is not the priority. Considering option 2, serving meals with paper and plastic containers can reduce the risk of cuts during a mealtime seizure. But this measure is limited, not always necessary, and does not address the greater risk of falls or head trauma. Finally, option 4, applying soft limb restraints, is absolutely contraindicated. Restraining a client during seizure activity can worsen musculoskeletal injury, restrict circulation, and even compromise the airway. Instead, nurses should allow free movement while keeping the client safe from sharp or hard objects. The key clinical takeaways are that maintaining the bed in the lowest position is the essential priority to prevent injury, while additional precautions, such as padding the side rails, keeping suction and oxygen ready at the bedside, and ensuring a calm environment, support safety but are secondary to this foundational intervention. Always remember, seizure care aligns with ABCS and safety above all. Here is a Stan Coast Pearl to help you memorize this. Think of the phrase SAFEBED. This stands for suction ready, airway maintained, flatbed in the lowest position, environment dim and quiet, bed rails padded, emergency call light nearby, and do not restrain movements. This acronym will help you recall the most essential seizure precautions quickly during both exams and clinical practice. Let us now move into a highly testable NCLEX scenario that focuses on preparing a client for an electroencephalogram, or EEG, to evaluate recurrent seizure activity. The question asks, which pre-procedure intervention is the most appropriate to ensure accurate test results and client safety? The options given are: administer a prescribed sedative 1 hour before the test, instruct the client to remain NPO after midnight on the day of the test, assist the client with thoroughly shampooing the hair before electrode placement, or obtain lying and sitting blood pressure measurements before the procedure. The correct answer is option 3, assist the client with thoroughly shampooing the hair before electrode placement. An EEG is a non-invasive test that records the brain's spontaneous electrical activity using electrodes placed on the scalp. For the electrodes to conduct accurately, the scalp must be clean, dry, and free from oils, gels, or sprays. Shampooing the hair ensures strong electrode adherence, minimizes electrical interference, and prevents false readings. Without this preparation, test accuracy is compromised. Looking at the other options, option 1, administering a sedative, is inappropriate unless specifically ordered for a sleep EEG. Sedatives and anticonvulsants suppress brain activity, potentially masking seizure discharges and leading to false negative results. Moving to option 2, withholding food and water is not required for an EEG. In fact, fasting can lower blood glucose levels and increase seizure susceptibility, which may place the client at unnecessary risk. The only restriction is avoiding caffeine for at least 8 hours before the procedure, since caffeine alters brainwave activity. Finally, option 4, obtaining lying and sitting blood pressure measurements, may be relevant for evaluating orthostatic changes, but has no direct impact on EEG results or electrode placement. Vital signs may be checked routinely, but they are not the priority nursing action here. From a clinical perspective, other key considerations include withholding sedatives, stimulants, or anticonvulsants as directed, and sometimes using sleep deprivation to provoke abnormal activity for recording. Teaching the client is equally important, clarifying that the EEG is painless, does not involve electrical shocks, and generally lasts 30 to 60 minutes. After the procedure, clients may safely resume their usual activities unless otherwise instructed. Here is the high-yield memory aid to anchor this concept. Stan Coast Pearl. Clean scalp, clear signals. For an EEG, shampooing the hair is the single most critical preparation step, along with avoiding sedatives, caffeine, and hair products to guarantee accurate results. Let us now shift into a critical safety scenario that often appears on the NCLEX and requires sharp prioritization skills. Imagine a client undergoing an electroencephalogram who suddenly begins to convulse during the procedure. The nurse must immediately determine the first action to ensure client safety and prevent complications. The options provided are: administer oxygen by nasal cannula, measure the blood pressure and pulse, check the client's pupils, or place the client in a side-lying position. The correct answer is option 4, place the client in a side-lying position. The reasoning is straightforward but deeply important. During a seizure, the highest nursing priority is always to maintain airway patency. When tonic-clonic activity occurs, the client may lose consciousness, experience generalized rigidity, and produce excess oral secretions. which place them at high risk for aspiration. By turning the client onto the side, the nurse allows saliva, vomitus, or blood to drain freely and prevents the tongue from occluding the airway. This position is both quick and effective, aligning with the ABC framework, airway, breathing, circulation, and Maslow's hierarchy, where physiologic survival needs come first. Looking at the incorrect options, it becomes clearer why they are not the priority. Administering oxygen by nasal cannula, although supportive, cannot be done safely until the airway is open. Giving oxygen through a blocked airway only delays effective ventilation. Measuring blood pressure and pulse is part of post-seizure monitoring, but does not prevent immediate life-threatening complications. Similarly, checking pupils is a valuable neurologic assessment, but attempting this during active convulsions is unsafe and provides no immediate protection for the client. Therefore, the safest and most immediate intervention is to place the client in a side-lying position. Once the seizure subsides and the airway is secure, the nurse can proceed with oxygen administration, vital signs, and neurologic checks. Here is a clinical pearl to lock this concept in your memory. Airway first, assessment later. In all seizure scenarios, positioning to protect the airway is the first priority. Never restrain the client's movements, but do clear the area to prevent trauma. Always keep suction and oxygen equipment at the bedside for clients at risk of seizures. And finally, once the client enters the postictal phase, document carefully. Time of onset, duration, movements, level of consciousness, and recovery details, which will all provide vital diagnostic data to guide treatment. To level up your preparation here is the fastest way to upgrade your NCLEX prep. The Ultimate NCLEX Crash Course is a complete start-to-finish system, already trusted by more than 100,000 nursing students who passed. You get interactive live classes, easy-to-watch recorded lectures, 5,000 exam-style questions, 30 full practice tests, ebooks and PDF notes, a student planner, and next-generation NCLEX questions, broken down step by step. This is not just another review. It is everything in one place. Scan the QR code or use the link in the description to enroll now and unlock free PDF notes, practice tests, and NCLEX quizzes. Plus, join our Telegram and WhatsApp channels for ongoing free resources. Let us get you to a first-time pass. Let us now explore another critical NCLEX-style scenario that focuses on accurate seizure documentation, something that every nurse must master during clinical practice. A nurse is documenting care for a client who experienced a generalized tonic-clonic seizure during hospitalization. The question is, which documentation entry provides the most diagnostically valuable initial information for the healthcare team? Here are the possible options to consider. Option A is documenting the exact time the seizure began. Option B is recording the total duration of the seizure activity. Option C is noting the client's mood and behavior immediately before the seizure. Option D is writing down the client's verbal comments immediately following the seizure. The correct answer is option B, the total duration of the seizure activity. This is because the duration is the single most critical factor that guides both immediate intervention and diagnostic classification. For example, seizures lasting longer than 5 minutes meet the definition of status epilepticus, a neurological emergency that requires urgent administration of benzodiazepines, rapid airway support, and escalation of care. By documenting the seizure's length, the nurse equips the healthcare team with information that directly influences the urgency of treatment and the prevention of life-threatening complications, like cerebral hypoxia, metabolic acidosis, and arrhythmias. Now, let us examine why the other options, although important, are not the top priority. Option A, the exact start time of the seizure, provides helpful context but does not communicate severity without knowing how long the seizure persisted. A seizure that begins at 10:05 and stops at 10:08 has far different clinical significance compared with one that continues past 10:20. Option C, describing the client's mood and behavior before the event, may help identify prodromal auras or potential seizure triggers, which can guide long-term management. But this data does not affect immediate safety. Option D, noting the client's verbal comments after the seizure, is useful for postictal assessment and neurological evaluation, yet it remains secondary to knowing whether the seizure posed an acute risk to survival. From a clinical integration perspective, the seizure duration directly aligns with the ABC framework, airway, breathing, circulation, as well as Maslow's physiologic needs. Since prolonged seizures elevate aspiration risk, threaten oxygenation, and may progress to cardiac complications. Evidence-based neurology guidelines consistently stress documenting onset, duration, motor characteristics, interventions, and recovery, with duration being the strongest predictor of whether escalation is required. In terms of safety, accurate timekeeping of seizure activity allows nurses and providers to distinguish between a self-limiting seizure versus one demanding emergency action. Here is your Stan Coast Pearl. Seizure documentation starts with duration, because seconds decide survival. Always remember to capture the onset, total duration, motor activity observed, interventions provided, and postictal status. But keep in mind that the duration determines how urgent the response must be and whether the seizure might progress into status epilepticus. Moving forward into another high-stakes clinical situation, imagine a nurse entering a hospital room and finding a client experiencing a generalized tonic-clonic seizure. The immediate question becomes, which nursing interventions must be carried out without delay? The options include calling the client's name repeatedly to assess responsiveness, holding the client's body firmly to prevent injury, placing an emesis basin close to the client's mouth, rolling the client onto the side, removing nearby objects that could cause injury, and activating a rapid response or notifying respiratory therapy for airway support. The correct actions are rolling the client onto the side, removing environmental hazards, and activating rapid response or respiratory support. In other words, options 4, 5, and 6. Here is the reasoning explained step by step. Beginning with the first option, calling the client's name, this is incorrect because a tonic-clonic seizure almost always causes loss of consciousness. Calling the name does not restore airway or prevent complications, so it wastes critical time when safety should be the focus. Shifting to the second option, attempting to hold the client's body firmly during seizure activity is unsafe. Forcefully restraining a seizing client can cause fractures, dislocations, or soft tissue injuries, while offering no benefit in stopping the seizure or improving oxygenation. Moving on to the third option, placing an emesis basin close to the mouth is also inappropriate. During an active seizure, the jaw is usually clenched tightly, and trying to insert or place objects near the mouth risks broken teeth, aspiration, or airway obstruction. Now, let us turn to the correct answers. Option 4, rolling the client onto the side, is correct because the side-lying recovery position maintains a clear airway and allows secretions or vomitus to drain safely. This simple action directly aligns with airway protection in the ABC priority framework. Next, option 5, removing nearby objects, is correct because sharp or movable items like IV poles or furniture can cause traumatic injury if the client strikes them during convulsions. This follows NCLEX's safety and risk reduction principle. Finally, option 6, activating rapid response or calling respiratory therapy, is correct because escalation of care is essential in case the seizure progresses to status epilepticus, defined as seizure activity lasting longer than 5 minutes. Early mobilization of advanced support ensures access to oxygen therapy, suction, emergency medications, and airway management to prevent cerebral hypoxia and life-threatening arrhythmias. Stan Coast Pearl, during seizures, do not waste precious seconds on calling names or restraining limbs. Focus instead on airway, breathing, and safety. Roll to the side, clear the environment, and be ready to escalate care if the seizure does not stop. Let us now explore another high-priority legal and safety scenario that nurses often face in clinical practice. Imagine a hospitalized client sustaining an injury during a tonic-clonic seizure. The question becomes, to minimize liability in the event of legal action, which fact is the most essential to include in the nurse's incident report? Here are the options to consider. Option A, the client was assigned to a licensed nurse. Option B, the signal or call cord was placed within the client's reach. Option C, the client's vital signs were documented as stable before the seizure. And option D, the client was last observed reading in bed. The correct answer is option B. The signal or call cord was placed within the client's reach. Here's the reasoning behind this choice. Including the fact that the call cord was accessible demonstrates that the nurse complied with institutional safety policies and client safety standards. In the event of an injury-related lawsuit, the primary legal concern is whether safety precautions were in place and documented. By confirming that the client had the ability to summon help if needed, the nurse shows adherence to expected professional standards, which is one of the strongest defenses against negligence claims. Looking at option A, stating that the client was assigned to a licensed nurse may sound important, but it does not reduce liability. Both registered and practical nurses are expected to maintain safety standards. Therefore, liability rests not on designation, but on the nurse's actions. Turning to option C, documenting stable vital signs is clinically relevant but legally insufficient. Vital signs reflect medical status, not the nurse's compliance with safety measures such as seizure precautions, accessible call bells, or hazard-free environments. Finally, option D, noting that the client was last observed reading in bed, adds nothing of legal weight. Courts and regulatory bodies focus on whether protocols and safety policies were followed, not on a client's leisure activity. To bring this all together, let us highlight the key clinical and legal insights. First, always remember that incident reports should demonstrate compliance with safety precautions, such as side rails, call cord access, or fall prevention. Second, vital signs are crucial for continuity of care but do not reduce liability risk. Third, professional licensure does not shield a nurse from liability if safety standards are ignored. And finally, the most defensible documentation in legal proceedings is clear evidence that hospital policy and safety standards were followed. Stand coast. Pearl, in situations where injury occurs, liability often depends less on clinical details and more on whether safety measures were maintained and documented. Always protect your practice by ensuring safety standards are visible in your charting and incident reports. Let us move into the next important practice question to strengthen your NCLEX preparation. A client has just experienced a generalized tonic-clonic seizure and is now entering the postictal recovery phase. The nurse needs to anticipate what will most likely occur first during this stage. Here are the options to consider. Option 1, excessive jerking of the entire body. Option 2, staring with a brief loss of consciousness. Option 3, fluttering of the eyelids and movement of the lips. And option 4, confusion followed by deep sleep. The correct answer is option 4, confusion followed by deep sleep. Now let me explain why this is the correct choice. After a tonic-clonic seizure, the brain enters a period of recovery known as the postictal phase. This phase is marked by profound neurologic exhaustion because of intense hypersynchronous firing of neurons during the seizure. The client commonly demonstrates confusion, disorientation, fatigue, and often drifts into a deep sleep. This is the earliest and most expected clinical manifestation. Additional features may include headache, muscle soreness, or even temporary neurologic deficits such as Todd's paralysis. The nurse's responsibility here is to ensure airway protection, maintain a side-lying position to reduce aspiration risk, and provide oxygen and seizure precautions until the client regains baseline awareness. Switching focus to why the other options are incorrect, let us first analyze option 1, excessive jerking of the entire body. This represents the clonic phase of a tonic-clonic seizure, not the postictal state. Once the clonic jerking ends, the client does not resume jerking activity, but instead progresses into exhaustion and decreased responsiveness. Moving on to option 2, staring with a brief loss of consciousness, this is more consistent with absence seizures, which are seen commonly in children. These seizures cause momentary lapses in awareness, with immediate recovery and no postictal confusion, which makes this finding unrelated to a tonic-clonic seizures recovery phase. Finally, option 3, fluttering of the eyelids and movement of the lips, describes automatisms, which are features of absence or focal seizures. They do not appear in the postictal period of a generalized tonic-clonic seizure. Instead, the dominant features will always be confusion, drowsiness, and a tendency towards sleep. Here is the key clinical insight, also known as the stand-coast pearl. The postictal phase is a hallmark of generalized tonic-clonic seizures and is always characterized by neurologic exhaustion, not by continuation of seizure activity or automatisms. For NCLEX success, remember that airway safety, positioning, and monitoring are the nurse's highest priorities during this stage. A good exam strategy is to carefully note words like first or most likely, which direct you to select the expected and immediate clinical sequence rather than unrelated seizure patterns. Let us smoothly transition into this critical NCLEX-style scenario, where prioritization is the key to saving a life. A nurse is caring for a client who has just experienced a tonic-clonic seizure. The seizure activity has ended, and the client is now in the postictal phase, presenting with drowsiness and intermittent snoring respirations. The question asks, which nursing intervention takes priority at this time? Here are the possible options to consider. The first option is to assess the client's level of arousal. The second option is to assess the client's breathing pattern. The third option is to reorient the client to the surroundings. The fourth option is to change the client's clothing. The correct answer is option 2, assess the client's breathing pattern. This is the most important action because in the immediate postictal phase, the airway and breathing are at the highest risk of compromise. Seizures often result in decreased consciousness, relaxation of airway muscles, pooling of secretions, hypoventilation, or irregular respirations. These factors can quickly progress to hypoxemia or aspiration if not identified and managed promptly. Using the ABC framework, airway, breathing, circulation, and Maslow's hierarchy, physiologic stability always comes before neurologic or comfort measures. Therefore, the nurse must carefully evaluate respiratory rate, rhythm, oxygen saturation, and chest expansion, while also preparing suction and oxygen equipment. Administering oxygen may be required if saturation drops or if ventilation is inadequate. This intervention directly prevents potentially fatal complications and is therefore the top priority. Now, let us examine why the other options are incorrect. Assessing the client's level of arousal, while important for ongoing neurological checks, is not the immediate concern. Drowsiness and confusion are expected postictal findings, and focusing on this too soon could allow dangerous hypoxia or aspiration to develop unnoticed. Moving on to reorientation. This is a useful step once the client regains alertness. But in the immediate postictal phase, the brain is still recovering. Attempting reorientation at this time is both ineffective and neglects the more urgent need for respiratory stability. Finally, changing the client's clothing may be necessary if incontinence occurred during the seizure, but hygiene and comfort measures are the lowest priority. They can only be addressed after airway and breathing have been stabilized. Here comes your Stancoast Pearl. On the NCLEX, if you see the term postictal phase, immediately apply the airway and breathing first principle. Postictal confusion and incontinence are common but non-life-threatening, whereas hypoxia and aspiration can become fatal within minutes. To enrich this with high-yield insights, remember that postictal findings typically include confusion, fatigue, headache, muscle soreness, and sometimes Todd's paralysis, which is a temporary weakness on one side. Nursing actions should include positioning the client on their side to facilitate secretion drainage, assessing airway and breathing, and administering oxygen if necessary. By always applying the ABC framework before considering neurologic checks or comfort measures, you can prioritize correctly in both clinical practice and on the NCLEX. Let us now transition into a life-saving emergency care scenario involving a client with epilepsy. A 32-year-old client has a documented history of 2 episodes of status epilepticus within the past year. During a routine admission, the nurse reviews the medical record and notes that seizure precautions are in place. The critical question arises: which emergency medication should the nurse ensure is readily available at the bedside if another episode of status epilepticus occurs? Here are the available options to consider. The first option is diazepam, also known as Valium. The second option is Phenytoin, or Dilantin. The third option is carbamazepine, commonly referred to as Tegretol. And the fourth option is phenobarbital sodium, also known as luminol. The correct answer is option 1, diazepam or Valium. This drug is classified as a benzodiazepine and acts rapidly by enhancing the effect of gamma-aminobutyric acid, or GABA, which is the brain's primary inhibitory neurotransmitter. By boosting GABA activity, diazepam quickly suppresses the abnormal neuronal firing that drives continuous seizure activity. Status epilepticus, defined as a seizure lasting more than 5 minutes or recurrent seizures without regaining consciousness, is a true neurologic emergency. Without rapid pharmacologic intervention, complications such as hypoxia, metabolic acidosis, cerebral edema, and permanent brain damage may occur. Intravenous benzodiazepines like diazepam or lorazepam are considered first-line rescue medications because they act within minutes to terminate the electrical storm in the brain. For the NCLEX, remember that airway, breathing, and circulation stability depend on immediate seizure control, which makes diazepam the most important medication to keep at the bedside. Now let us analyze why the other options are not correct. Phenytoin, or Dilantin, though an effective anticonvulsant for long-term seizure prevention, does not act quickly enough for an emergency situation. Its mechanism involves stabilizing neuronal membranes by blocking sodium channels, but its onset is too slow to stop an active seizure. Instead, it is used after benzodiazepines to prevent seizure recurrence, making it a second-line drug in this context. Moving to carbamazepine, or Tegretol, this medication is primarily prescribed for partial seizures and tonic-clonic seizures in an outpatient setting. It is only available in oral form and has a delayed onset of action, which means it is completely inappropriate for status epilepticus, where immediate intravenous intervention is required. Finally, phenobarbital sodium, or luminol, though it enhances GABA and can depress seizure activity, is not first line because of its slow onset and its risk of causing severe respiratory depression. It may be considered when benzodiazepines and phenytoin fail, but it is reserved as a third-line option. To close this reasoning, let us highlight the high-yield NCLEX insights. Status epilepticus always requires immediate intravenous benzodiazepine administration. Diazepam and lorazepam are both correct first-line rescue drugs, with lorazepam often preferred due to longer duration, but diazepam is just as appropriate in emergencies. Phenytoin and phenytoin are second-line drugs to maintain control after the seizure is stopped. Phenobarbital is a fallback third-line agent, and carbamazepine has no role in acute seizure management. Here is your Stan Coast Pearl. Whenever you see the word status epilepticus on NCLEX, instantly connect it with give benzodiazepines first. Long-term agents like Phenytoin or carbamazepine are important for prevention, but in the emergency moment, rapid benzodiazepine therapy equals survival. Let us now move into another essential NCLEX-style scenario that highlights the importance of client education. A nurse is preparing discharge teaching for a client-prescribed phenytoin sodium, also known as Dilantin, for long-term seizure management. The nurse must emphasize which self-care practice is most essential to help prevent a common adverse effect of this medication. Here are the options to consider. Option 1 is shampooing the hair frequently to maintain scalp hygiene. Option 2 is trimming fingernails weekly to avoid injury. Option 3 is brushing the teeth at least twice daily with thorough oral care. Option 4 is taking daily baths with mild soap to protect skin integrity. The correct answer is option 3, brushing the teeth at least twice daily with thorough oral care. Phenytoin sodium, while effective for seizure control, is well known for its adverse effect of gingival hyperplasia, which is the abnormal overgrowth of gum tissue. This occurs due to fibroblast proliferation and collagen deposition, resulting in gums that are swollen, tender, and prone to bleeding. Over time, this condition can interfere with chewing, speaking, and maintaining oral hygiene, while also increasing the risk of secondary infection. Consistent and meticulous oral hygiene, including brushing at least twice daily, flossing, gum massage, and regular dental visits, is the single most effective preventive strategy. Reinforcing this practice empowers clients to reduce gum overgrowth and preserve oral health while continuing long-term phenytoin therapy. Turning now to why the other options are incorrect, let us begin with option 1, frequent shampooing of the hair. While scalp hygiene is certainly beneficial, it has no connection to phenytoin's adverse effects and does not reduce the risk of gingival overgrowth. Moving to option 2, weekly trimming of fingernails, we can say that although nail care is important for general cleanliness, phenytoin is not associated with nail complications, making this irrelevant in preventing drug-specific side effects. Finally, option 4, daily bathing with mild soap, helps maintain skin integrity. But again, this intervention does not address the oral tissue changes directly caused by phenytoin. Here's a Stan Coast Pearl to lock this concept into your memory. On the NCLEX, when you see phenytoin, always think gingival hyperplasia, and the prevention strategy is excellent oral care and regular dental checkups. The clinical takeaway is clear. Phenytoin therapy requires more than just monitoring seizure activity. It also demands focused education on gum health. Teaching clients about proper oral care is not simply a matter of comfort, but one of safety, infection prevention, and long-term quality of life preservation. Thanks for watching. Like, subscribe, and hit the bell. Scan the QR or use the link for free notes and quizzes. Join us on Telegram and WhatsApp for daily NCLEX boosters. See you in the next high-yield class.